In this video, we'll cover chapter 2 and some of the um, important historical events in clinical psychology. So when we think about the origins of the field, psychology in general was originally derived from the teachings of philosophers. So for thousands of years, we've had ideas about psychology, but it didn't really become a field until a few hundred years ago. And when you think about modern times, when you think about what a psychologist is, that often refers to somebody who's a clinical psychologist who practices psychotherapy or assessment. But it actually wasn't until the 20th century that clinical psychology as a field existed. So we had psychiatry earlier, but we did not have clinical psychology as we think of it now until the 1900s. So I'm going to pose a discussion question here. So if clinical psychology did not exist until the 1900s, how do you think communities treated people with mental health problems before that? So you can think way back in time or in the 1800s, but just thinking about like, how do you think a community would treat somebody who had serious mental illness? So now I'm going to walk through some of the important figures in the reform of mental health care, not just in the US, but just more generally. So one of the early figures was William Tuke. And what he really focused on was improving the conditions of asylums in England. And so in England, asylums were essentially prisons. So people were chained up, they were, kept alive with food and water, but they weren't provided any sort of care. So William Tuke opened the York Retreat, which was the first institution that attempted to provide humane care to people with severe mental illness. And so this was originally open to Quakers. It actually continues to operate to this day, but now it's like an outpatient clinic. But the reason why the York Retreat was important is that this was the first time what they called moral care was provided for individuals with mental illness. So instead of it just being prison conditions to keep them alive and off the streets, it became this idea that there could be a humane treatment. And we're going to talk a little more, but there's current facilities that are ultimately inspired by this first institution. So then we had Philippe Pinel. And so Pinel was in France, so nearby England. He was working around the same time, but he was advocating that people with mental illness should be removed from dungeons in France because that's where they were being kept. And so he advocated that it's actually important to maintain a patient's case history and to keep ongoing treatment notes and to start classifying what their illness is. And this is important. This is something we might take for granted now when you think about medicine or clinical psychology. But this was the first time somebody was advocating for this in these asylums. And this really, it implies a degree of interest in treating the mental illness rather than just keeping them away from society. So the reason to keep notes on somebody is because you're trying to monitor their progress. And this implies an interest in ultimately understanding what the outcomes are. Pinel is also known for his treatise on insanity. So this was like a big document he wrote that outlined his goals of wanting to provide empathy and support for people with mental illness rather than ridicule and punishment. And I put this quote on the right in purple. This is from Hegel's Philosophy of Mind from 1790. And I just think it's an interesting quote to read because it also shows how Pinel's work in trying to reform the social institutions was also influencing kind of philosophy of mind and other fundamental theories in psychology at the time. In the United States, we have Eli Todd, who was a doctor in Connecticut. He heard about Pinel's work and he was like, we got to do this in the US. So he opened what's called the Retreat, which to me kind of sounds like a horror movie, but it's a real institution. But the cool thing about the Retreat is that unlike these kind of more prison-like institutions, it really emphasized the patient's strengths. And it also helped include the patient's input in their own treatment, which again was not a thing that happened before this. And so, around this time, he opened the retreat in Connecticut, and then similar institutions started to open up in other US states. And then last we have Dorothy Dix. So Dorothy was a Sunday school teacher working in a Boston jail. And she was like, okay, we have a couple of these hospitals, the retreat was open at that point, but there are way too few. There are not enough to really address mental illness in the United States. And so she realized that the people she was working with were often incarcerated due to mental illness or cognitive difficulties rather than criminal activity. She collected citywide data on the treatment of mentally ill people. So this was a very research-driven approach. And then she presented that data to community leaders and really advocated for more humane and adequate treatments. And so what this led to is the establishment of more than 30 state institutions throughout the US. So in Hawaii, we have the Hawaii State Hospital, and a lot of states have these state hospitals, and kind of the first ones came about from her efforts. So I want to pause for a moment and talk about kind of the impact of these efforts. So these 4 people were very important in starting the reform of what was essentially, imprisoning people who had mental illness. They were bringing the first indication that you could actually help somebody or provide them with humane treatment or that they could get better. And so that really laid that groundwork for understanding that mental illness is something that can improve, and it's not something that should be punished. But, when we think about these institutions in modern times, these facilities still had significant flaws. So people were placed in these institutions for long periods of time. People were often forcibly institutionalized at these facilities. These hospitals, if anyone has seen the movie like One Flew Over the Cuckoo's Nest, they're not ideal places to be, and certainly not ideal. And so when we think about this, it's a good movement towards greater acceptance and respect for people with mental illness, but clinical psychology still had a really long way to go. At this point, the field of clinical psychology did not yet exist. So this is more about how is society even managing people with mental illness. And so, right about the turn of the 20th century, we have Lightner Whitmer, who is considered the person who created the field of clinical psychology. So he studied psychology under Wilhelm Wundt, you might remember from Intro to Psychology. And at this time, psychology was a purely academic discipline. So this is back when, they're taking these like philosophical ideas about human behavior, and they're doing some early studies to show that you can scientifically study human behavior. And so what Whitmer did is he founded the first psychological clinic at the University of Pennsylvania in 1896. And this is the first time that, like, on record, the science of psychology was systematically applied in a treatment setting. So that's kind of both using academic research in psychology, but applying it to a treatment setting. And so once he started doing this, it kind of just exploded from there. So by 1914, there were 20 clinics modeled on his ideas, and there were 150 clinics by 1935. And so Whitmer actually mostly worked with children. He took a very, very behavioral approach, and he worked with kids who were referred by schools, their parents, their doctors, or other community authorities. But he did believe that clinical psychology could be applied to adults as well. And interestingly, I think Freud is a much more well-known name, but Whitmer was not really influenced by Freud. He did not use the introspective psychotherapy techniques that Freud did. This was purely using, the academic study of psychology and applying it to treatment. So again, very behavioral based. Whitmer also founded the first clinical psychology journal called the Psychological Clinic. And the term clinical psychology was introduced in 1907. So thinking about the activities that clinical psychologists do, we have assessment and we have psychotherapy. So in terms of assessment, jumping back to the 1800s in Europe, they were very rudimentary ways of categorizing mental illness. So we had neurosis, which refers to mental illnesses that did not affect one's connection to reality. So things like anxiety or depression. And we have psychosis. So mental illnesses that include symptoms of hallucinations, delusions, or disorganized thinking. So something like schizophrenia. So that was basically it. You had neurosis and psychosis. Then we had Kraepelin, who used a different two-category system. So he split things into exogenous disorders, which are things caused by external factors, and he considered these to be more easily treated, and endogenous disorders, things that are caused by internal factors. And it's interesting, he was developing this system based on his ideas of how disorders came about, which is also kind of was an unheard of way of thinking about clinical psychology at the time. So he was starting to think about, where are disorders coming from? How are these symptoms related to what's going on for the person in their mind? He is also known for being one of the first people to assign names to more specific types of disorders. So he noted people who were experiencing symptoms that we would now call schizophrenia, and he called it dementia praecox. He also noted people who what he called autistic personality, as well as manic depressive psychosis, which is similar to modern day bipolar disorder. So he was the first to kind of describe some of these categories. So in the 1800s, the US Census also was recording mental disorders, but it was very rudimentary. So in 1840, there was just one category called idiocy and sanity. 1880, they expanded to 7 categories. But it wasn't until after World War II, when there was a need for the military to have a more standardized way of categorizing mental health problems, that the first DSM was published. So this was in 1952. We are going to discuss the DSM in much more detail in Chapter 7, but I encourage you to read the history of the DSM in the textbook in Chapter 2. And then in terms of assessment, so Chapter 2 does a basic overview of intellectual assessments and personality assessments. We're going to spend more time on that in a later week, but I do want you to read that section of Chapter 2 just to get the basic overview, but I won't be going over it in this video. In terms of psychotherapy, so now jumping ahead, we're in the 1930s. Most clinical psychologists are still working in academia. So we have Whitmer's clinics, which are almost all affiliated with universities. Most clinical psychologists are, working as professors, really trying to research and understand human behavior and how it relates to mental illness. It wasn't until World War II that there was a much greater demand for more clinical psychologists. So many soldiers came home with what they called shell shock, which is now what we might call post-traumatic stress disorder or PTSD. And so around this time, the Veterans Administration reached out to the APA to stimulate programs to train more clinical psychologists to address this issue. So they were saying, we have a lot of soldiers coming home with these symptoms. We know that clinical psychology is like this budding field that might have some answers, but we really need more clinical psychologists. And so this is around the time, after World War II is when the Boulder Conference happened. And so this was part of that, is standardizing graduate training so that there could be more clinical psychologists in the field. And when we think about assessments, World War II also had an impact on this. So cognitive tests and the original DSM, they were both originally designed to aid the military in identifying people who are fit for duty or who, after serving, like seeing what kinds of services they might need. But I am going to post a supplemental video that's from YouTube that was actually filmed in the 1940s. And, it's an optional video, but I think it's helpful to see kind of how people are talking about mental health in the 1940s. So feel free and comment on that if you have any questions or thoughts about that. Lastly, I just want to highlight the different waves of types of psychotherapy. So we're going to spend much more time on these later in the course, but over history, we had these different approaches that dominated at different times. So original approach was psychodynamic approach. And, this is thinking about Freud, Jung. This is really focused on making unconscious thoughts and feelings conscious. So the goal is to create insight. This was then challenged by the behavioral approach, which really took this scientific method, really only focused on observable, quantifiable problems, tracking progress, really focused on behaviors only. We also have humanistic therapy, which is focused on the client as a whole person, their relationships, their growth, and their self. Family therapy was pretty early as well. So thinking about mental illness as being potentially a product of being in a flawed system. So whether it's your family unit or your school, this idea that a group dynamic can impact mental illness. And then we have cognitive therapy, which has started in 1960s and is currently, I would say, the predominant type of therapy, although we'll talk about kind of the popularity about these different types of therapies. And cognitive therapy really emphasizes logical thinking and teaching people how to attend to their own thoughts and kind of challenge their own thoughts. So these are the different historical waves of psychotherapy. Something we'll talk about throughout the class is that there's this movement towards combining a lot of these approaches. Most modern therapists are not strictly in one school of therapy. They are drawing from, behavioral approach and humanistic approach and cognitive therapy, and they might still be using some psychodynamic approaches and considering the family unit. So we're going to be going through these in a historical manner, but also talking about how they look today. So that is it for chapter 2. As always, feel free to leave any comments with any questions or areas that you would like to know more about.